Welcome, everyone. Thank you so much for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell Eleanor Blum Patient Family Learning Center at Mass General Hospital. Before we get started, I just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that everyone is in listen-only mode. Everyone has been muted so that we can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat box. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a survey that we'd like to ask you to briefly complete. Your feedback is valuable to us as we plan future programs. So next, I would like to introduce you all to Dr. Ian Cooley. Dr. Cooley is a second-year rheumatology fellow at Mass General. His clinical and research interests include crystalline arthritis, musculoskeletal ultrasound, and medical education. He joins us today to give a talk on bursitis and tendinitis. Joining us today, we also have Dr. Mina Kola, joining as a faculty panelist. Dr. Kola is the director and founder of the Rheumatology Musculoskeletal Ultrasound Program at Mass General. Her clinical and research interests include inflammatory arthritis, musculoskeletal ultrasound, and injection procedures. So next, I'm going to hand it over to Dr. Cooley.
All right, great. Thank you, Amy, for that very kind introduction. And thank you, Dr. Keller, for being here as well. I'm excited to speak with everyone about bursitis and tendinitis. These are very common causes of non-arthritic musculoskeletal pain, as we will see. So my agenda for the talk today, we'll start with the basics. I'll review some of the associated anatomy. We'll review what exactly a bursa and a tendon are. Go through some terminology because that'll help us with the discussion of these different entities and these different concepts. Then we'll delve a little bit more deeply into bursitis and then tendinitis as well. We'll start off by coming at these topics in terms of the non-inflammatory causes of bursitis and tendinitis. And then I'll circle back around and talk about the inflammatory conditions that we as rheumatologists see a little bit more frequently, which can lead to bursitis and tendinitis. We'll review what we've learned, and then I expect we'll have plenty of time for questions near the end. All right, so to begin, what is a bursa, or what are bursae, which is the plural for bursa? So a bursa is a closed fluid-filled sac. There are many of them in the human body, somewhere in the order of 160. This can vary a little bit from person to person. And actually, interestingly, the body can form new bursa with time in some rare occasions. These bursae or fluid-filled sacs are often located near tendons and in areas of bony prominence. So we see one example on the right-hand side here. We're looking at a kind of a cartoon drawing of a shoulder. This is a right shoulder. I'd like to draw your attention to the subacromial bursa, which is kind of labeled in the middle on the left there. And its position is sitting just above the supraspinatus muscle and tendon, and between that tendon and a couple of bony prominences. And so this is common for bursae. They can overlie tendons and help protect them from the hard bony surfaces that the tendons may come up against. And they help with cushioning and gliding and free movement of tendons and other soft tissue structures to prevent damage due to bony structures and other hard things that could irritate the tendon or other structures. So to move on to tendons, if you look this up, you can find many variations on the theme in terms of a definition, but I thought this was a good one. A tendon is a structure made of fibrous connective tissue that connects muscle to bone. So we see a good example of this on the right-hand side of the screen. What we're looking at is, again, a drawing, a depiction of anatomy. So this is a person's arm with the long bone of the upper arm in brown towards the right-hand side on the upper part of the image. And in brown towards the lower side of the image are the two bones of the forearm. So this is the elbow joint. The muscles in the picture are the biceps muscles, mostly located in the upper arm. Those are depicted in red. And they coalesce into tendons on either side, the side that connects up to the upper arm and the side that connects down to the bone of the forearm, the radius. So the white part is the tendon part, and you can see how that connects the muscle tissue and the muscle fibers into the bone. And it allows the force and the energy that was generated by the muscle to connect with the bone and therefore move the bones and the joints. All right, so now I'll review a little bit of terminology, which I think will be important for this talk. And so we're going to talk about some suffixes. The first is itis. I think this is probably the one we've all encountered the most. Itis means inflammation. So there are any number of root words at the end of which we can add itis, and it means inflammation of a given structure. The ending osis means abnormal state, and a related suffix is opathy, which means disease or disease state. So in relation to this talk, we'll give some examples of the tendon. So if we use a root word for tendon and add itis, that's tendinitis or inflammation of a tendon. If we do the same thing with osis, that yields tendinosis, which is an abnormal state of a tendon. And adding opathy gives us tendinopathy or disease of a tendon. Now, if you're anything like me, when you first heard these terms, you might have been a little bit unclear on the difference between tendinopathy and tendinosis. By the use of the suffix itself, the meanings sound pretty similar. But in practical use, in the medical world, tendinopathy is the more general term that refers to a diseased tendon, whereas tendinosis refers to a non-inflammatory condition causing disease of a tendon. So tendinitis is an inflammatory condition of the tendon. Tendinosis is a non-inflammatory disease state, and tendinopathy is any sort of disease state, whether inflammatory or non-inflammatory. As one more example of the ending or the suffix itis, we have arthritis, which I imagine have all come across in some form or fashion, and this refers to inflammation of the joint. But that will not be the focus of our talk today, arthritis. So to put it in a visual format, we see that tendinopathy is the more broad umbrella term, which encompasses both tendinitis being inflammatory and tendinosis being non-inflammatory. So in the first half of the talk here, we'll focus on tendinosis and non-inflammatory causes of tendon pain and tendinopathy. And we can devise a similar scheme here for the bursa. So bursopathy would be a diseased bursa, bursitis referring to an inflammatory state. I included here bursosis with an asterisk just because this word is not really used very commonly. You can find it if you search for it, but that would be the logical extension of the use of the suffix here. So we'll focus on non-inflammatory bursopathy, non-inflammatory tendinopathy to begin with. So you may be asking how common these conditions are and why it's important for us to review and discuss today. The answer to that question is that it is a little bit difficult to assess. We know these conditions are common but likely underestimated. As may be intuitive to you, there are any number of people who have symptoms related to these conditions who either have not sought formal medical care or have not received a formal diagnosis and therefore would not be kind of included in studies and counted in terms of the prevalence or the frequency that these conditions exist. I've included at the bottom here on this slide a couple of more common tendinopathies. The first is lateral epicondylitis, which we'll discuss in a little bit more detail in a few minutes. One large study found that the incidence or the rate at which this condition develops is about 3 per 1,000 people each year. And Achilles tendinopathy, another common form of tendinopathy, is about somewhere in the same ballpark, about 2 or 3 per 1,000 people each year. And these numbers may sound very small if we're talking about just a few per 1,000, but this is the development of the condition each year. And if we were to multiply this out over the span of someone's life, 60, 70, 80 years or more, the numbers start to add up. And each of these conditions refers to a tendinopathy in just one location or one tendon. When we consider the dozens and dozens of tendons we have in the body, there's much more opportunity for people to develop tendinopathies. So we can see how these conditions are actually quite common. And in the aggregate, tendinopathies and bursopathies are responsible for the majority of pain and debility and loss of time at work that is not otherwise accounted for by arthritis. All right, so we'll jump into first into bursopathy. And so I'd like to review some of the more common locations that people can develop a bursopathy. The first is the Olecranon bursa. And so we have a clinical image or a photograph at the top here on the right, and a cartoon or a drawing on the bottom right to demonstrate the Olecranon bursa. This sits just on the back side of the elbow over the bony prominence that you could feel with your hand on your own elbow. As a bursa, as I mentioned earlier, it's a fluid-filled closed sac. In the normal healthy state, there is a minimal amount of fluid in that sac. So it's not something you could see or feel yourself if you have a normal healthy bursa there. But in the diseased state, as is common across pretty much all the bursopathies, it can develop quite a bit of fluid to the point that it's swollen and very prominent, as it is in the photograph here and in the accompanying drawing. You can also see in the drawing how the bursa can sit on top of the bone to cushion it. This is an area where many of us spend a lot of time putting pressure over the bony surface. And you can see also the vertical white line is the triceps tendon that attaches and inserts right next to the bursa. So this bursa can help that triceps or arm muscle tendon move freely and help the elbow joints move freely. So it is that the frequent contact with hard surfaces and repeated minor traumas that is the most common cause of bursopathy in this area. And it typically presents, patients come to medical attention because of the swelling associated with it. It can be uncomfortable, it can be painful, but many times it's minimally uncomfortable for the patient if the underlying cause is repeated microtraumas. Other causes of olecranon bursopathy include hemorrhagic bursopathy or bleeding into this space. That can occur with some form of trauma to the area and is more frequent in patients who are on blood thinners or have other reasons to have a propensity for bleeding. Some folks can develop a bursopathy here with more acute rather than repetitive trauma, but that's a little bit less common. All right, next on the list is greater trochanteric bursopathy. And we have a nice figure here on the right-hand side to demonstrate the greater trochanteric bursa. So this sits over the bony prominence of the femur, which is the large bone of the thigh, which makes up part of the hip joint. And the greater trochanteric bursa sits among a number of tendons and muscles, which are not depicted in this image, but they're muscles that attach between the greater trochanter and the rim of the pelvis. And this bursa in the normal healthy state helps those muscles have some cushioning and protection from the large bony prominence, and helps them move and glide easily when we walk or squat or otherwise move the hip and the thigh around. This is a common area for the development of bursopathy. It can cause a deep pain or tenderness over the lateral or the side aspect of the hip. And many times patients come to medical attention because they have pain or often tenderness in this area, which can interfere with sleep. When someone sleeps on their side, they often put a weight or pressure on this area, and that can cause symptoms and symptoms and aggravate the bursopathy in the area. This condition used to be referred to primarily as greater trochanteric bursitis. As I discussed a couple of slides back, oftentimes bursopathy, which is a little bit more of a general term, is more encompassing and more appropriate. And we've come to understand that some percentage of the patients who have these symptoms do not in fact have a bursopathy, and instead their symptoms are simply the result of tendinopathies and other abnormalities of the muscles in the area. So we'll discuss that a little bit further in a few slides. Next on the list is subdeltoid, also referred to as subacromial bursopathy. And so this bursa is in the shoulder, and we have a nice depiction on the right-hand side of the screen. Here we have a drawing. We're looking at someone's right shoulder in cross section. So we're looking kind of split down the middle of the shoulder. And the bursa itself is highlighted in the blue color. You can see how it sits in between and kind of wraps around a number of the muscles and tendons, as well as the humerus, which is the large, long bone that makes up the upper arm and is a part of the main joint of the shoulder. So this bursa is actually quite large and extensive. We can't see the full extent in this one drawing, but it kind of lays over and wraps around a number of these muscles and tendons, and is especially helpful for the free movement of the shoulder, which can move in so many directions. Because the shoulder can move in so many directions and there's so many muscles and tendons and areas of bony prominence, this bursa is relatively susceptible to irritation, just mechanical irritation and compression, particularly if there's also disease of the tendons. And by that, I mean a tendinopathy. And so bursopathy here of the subacromial bursa is commonly seen in conjunction with tendinopathies in the shoulder, which again, we'll cover in a little bit more detail. Patients often come to attention due to pain, stiffness in the shoulder. They can, if they have quite a bit of swelling in the bursa, they can sometimes have detectable swelling of the shoulder. And there's often tenderness in the area. This can be in the front of the shoulder, on the side, and or in the back part of the shoulder. There are certain things that may predispose to bursopathy in this area. And some of the better established risk factors would be overhead activities, including occupational activities, activities at home that require reaching overhead, especially if there's sustained overhead positioning, and overhead sports with overhead, repetitive overhead activities such as tennis. All right, next is retrocalcaneal bursopathy. So here we've moved down to the foot. You can see this is kind of on the backside of the foot and the ankle. Here, the normal retrocalcaneal bursa is tucked in just on top of and behind the bottommost and backmost heel bone called the calcaneus. It's also tucked just in front of the Achilles tendon, which we can see as the vertical white line. And it's a very small bursa filled with a minimal amount of fluid in the normal healthy state. With repetitive stressors, which could be activity related and is sometimes related to compressive footwear or something that may rub on the backside of the foot and ankle. This area can develop a bursopathy and fill with fluid. So there can at times be detectable swelling here. It often presents with a posterior or backside of the foot, backside of the ankle predominant pain and tenderness. Sometimes patients report predominantly discomfort when wearing shoes or wearing other footwear because it compresses this already irritated area. And last but not least is prepatellar bursitis. So the prepatellar bursa sits just on top of the patella, which is the kneecap. And it's a very superficial bursa, much like the Olecranon bursa was. It sits just underneath the skin. Because of this superficial location, it is susceptible to minor traumas, just in the way that the Olecranon bursa was. So the most common cause of bursopathy or bursitis here is repeated microtrauma and irritation. This area is, can become an issue in folks who do repetitive kneeling movements in particular, because they often put weight directly over the patella and compress, and sometimes cause a shear force on the bursa in this area. In this case, the example on the right-hand side is a clinical photograph. This is actually a bursitis. It's an inflammatory cause of bursopathy, so perhaps not most appropriate for this slide, but we'll cover that a few slides from now. All right, so I've covered some of the more common causes of bursopathy, at least the non-inflammatory ones. So you may be wondering how we come to a diagnosis of bursopathy. So history and physical exam are certainly the most useful tools at our disposal to make a diagnosis, particularly in the case of the prepatellar bursopathy and the Olecranon bursopathy, where the bursa is so superficial it's right underneath the skin. The physical examination can really tell the story there. And delving into the history, the patient's history can often provide good clues as to what may have irritated the bursa. Imaging can be helpful, especially for the deeper seated bursa, particularly in the shoulder and the hip, because those are less easily seen and less easily felt on examination. So an example of that is on the right-hand side of the screen here. This is an ultrasound image looking at the shoulder. Towards the bottom bottom part of the image is deeper into the patient's body. We see the bright white line that makes out a triangle. That's the bone or the humerus. Just on top of that is a rather large black area, and fluid on ultrasound shows up as black. So this is fluid that's distending the subdeltoid or subacromial bursa in the shoulder. So this may be a patient who comes into the office with pain. They may or may not have a little bit of swelling in the area. And if the physician suspects but has difficulty confirming that they have a bursopathy, getting something like an ultrasound and seeing this image would really confirm that suspicion for the treating physician. And I mentioned here that blood work is generally not useful. I'd say this is true in the sense of it would not be able to hone us into the bursa being a problem rather than the bone or the muscle or a tendon. It's really the physical exam, the history, and the imaging that can hone us into the bursa being the site of the issue or site of the problem. All right, so a brief word on treatment. There are a number of different potentially appropriate treatments for bursopathy. These will vary to some degree based on the patient themselves, the location of the bursa, the cause of the bursopathy, and what's been tried in the past for that patient. So RICE is an acronym you may have come across before for rest, ice, compress, and elevate. This is probably most applicable to the superficial bursae, such as the Olecranon bursa over the elbow and the prepatellar bursa over the front part of the knee. Other interventions, analgesics or pain control can be important if the bursopathy is especially symptomatic for a patient. Among the pain control options are the NSAIDs, or non-steroidal anti-inflammatory drugs, such as ibuprofen, also called Motrin or Advil, and naproxen or Aleve. There are many others in this category. Those can help control the pain and the discomfort, as well as some of the swelling in the bursa. Both physical and occupational therapy can be helpful for symptoms and helpful to in particular take stress, help a patient reduce stress on bursa that are subject to repetitive tasks and repetitive movements. If those things aren't helpful, corticosteroid injections, like cortisone injections, can be helpful to kind of calm down the area and reduce swelling in the bursa. And we're seeing examples of that in the photograph and the cartoon on the right-hand side. These are using an ultrasound to guide the needle into the appropriate place within the bursa itself. And then if all of the above have not worked for a patient, surgery can be considered, but this is really an intervention of last resort. All right, so we've covered the bursa. We'll move on to address the tendons now, the tendinopathy. So I mentioned with the subacromial or subdeltoid bursopathy that it was often seen in conjunction with tendinopathies in the shoulder. And this is, generally speaking, rotator cuff tendinopathies. So the rotator cuff is made up of four muscles and their associated tendons that help to control the movements of the shoulder. And their tendons come together and form a cuff, and they insert on and around the shoulder itself. Again, these tendons have a complex job because the shoulder moves in so many different directions, and they need to kind of weave in and around a number of different bony surfaces. So they're especially prone to being kind of pinched and irritated by the bony prominences in and around the shoulder. And that is the most common cause of the tendinopathy in these tendons. So they suffer repeated minor traumas and compressions that can lead to swelling and pain of the tendons themselves. The patellar tendon is a tendon in the knee. We're looking at the front side of the knee here on the right. It connects the patella or the kneecap to the tibia, which is one of the two main bones in the shin. And this helps to transmit force from the thigh to the leg. It helps us straighten our leg. It's used heavily in walking and running and other weight-bearing activity. And it is potentially under quite a bit of stress with some of these activities. So repeated stressors, sometimes associated with minor traumas and minor tears in this tendon, over time can lead to a tendinopathy, again with swelling, discomfort, tenderness, and pain of the tendon itself. Tennis elbow is another common cause of tendinopathy. I mentioned this one earlier, lateral epicondylitis. You can see in the image on the right-hand side, the lateral epicondyle is highlighted. This is on, excuse me, this is on the humerus, which is the long bone of the upper arm. It's kind of this knobby, bony prominence right here, where many of the tendons from the muscles of the forearm come and attach. So this is the lateral epicondyle on the bone. This is the attachment site of these tendons, which come from the muscles of the forearm. So lateral epicondylitis, the itis refers to inflammation. That's a little bit of a misnomer because the majority of patients with this condition have a tendinosis or a tendinopathy that's non-inflammatory in its nature. But repetitive movement, repetitive strain, sometimes microtrauma and small tear of the tendons in this area over time can contribute to a tendinopathy, once again with swelling, pain, discomfort, and tenderness. There are, as the name suggests, some activities that can predispose to this condition. Tennis, where someone has repetitive use, repetitive strain on the muscles and these associated tendons. But this is also true of other repetitive tasks. You know, people doing using a screwdriver or a hammer or other tools that require repeated use of the forearm muscles puts tension and stress on those tendons and can lead to a tendinopathy there. Golfer's elbow or medial epicondylitis or medial epicondylopathy is the analogous condition, but on the other side of the arm and the forearm. So this picture is highlighting the medial or the inside aspect where the muscles on the other side of the forearm coalesce into a tendon that again attaches to the humerus. And the concepts and the findings and the symptoms that patients experience are analogous on this side of the arm as well. The conditions, or rather the activities that predispose to this condition, are a little bit different. They're the ones that put stress and strain and repetitive use of a different set of muscles. That's the muscles on the front arm, front aspect of the forearm, rather than the back aspect of the forearm that lead to tennis elbow. And last but not least, in terms of the non-inflammatory tendinopathies, we have Achilles tendinopathy. So the Achilles tendon is the large tendon that comes down the backside of the lower leg and attaches to the calcaneus on the backside of the heel that we looked at earlier. It supplies the muscle, the gastrocnemius muscles and the soleus muscles, which help to plantar flex or extend the ankle. And so they put quite a bit of force and power. Those muscles are large and powerful muscles. And so the Achilles tendon has to transmit all that force into the ankle joint when we are walking, or even more force and strain when running. So over time, similar to the previous tendinopathies, there can be strain, repetitive minor traumas, minor tears that over time can lead to a tendinopathy with swelling, pain, and discomfort. So these features of diagnosis of tendinopathy are going to look familiar to you because they're essentially identical to that of bursopathy. The history and physical exam here are likewise key to the diagnosis. Imaging can be helpful, again, especially for deeper-seated tendons that are a little bit harder to examine, harder to see, harder to feel on the exam. And blood work is generally not going to be helpful for honing in on the tendon as the site of the problem in tendinopathy. The treatments, likewise, are going to look very familiar. These are the same kind of general themes that we saw for bursopathy. Rice with rest, ice, compress, elevate, control symptoms with analgesics, including the non-steroidal medications. Physical and occupational therapy can be especially helpful here. We're seeing an example of some of the exercises that can be helpful for Achilles tendinopathy. Corticosteroid injections are sometimes used. There's a little bit more risk associated with corticosteroid or cortisone injections around tendons, but they can be helpful in certain situations. And then surgery is, again, an option of last resort. All right, so now we're going to shift gears a little bit. We're going to go from the non-inflammatory world of tendinopathy or tendinosis into the inflammatory world of tendinitis and bursitis. So it was mentioned earlier on that I'm a rheumatology fellow, and so we often see inflammatory diseases. And so it's these sorts of inflammatory diseases that we see and diagnose and treat most often. And there are a handful of them that I'd like to introduce you to that can cause a tendinitis or a bursitis. So we're going to migrate over to the left side of the umbrella here for the remainder of the talk. So there are a few of these inflammatory conditions. The first is rheumatoid arthritis. This is one of the most common causes of inflammatory joint disease or arthritis. This affects up to maybe 1% of the adult population. And it's characterized mostly by inflammation of the joints. And we see a good example of that on the right-hand side here. If you look at the kind of middle row of the knuckles in this patient on both sides, they're quite swollen and likely quite inflamed. And that's common in rheumatoid arthritis. Now, the focus of the talk today is the tendons and the bursa. A little bit less common in rheumatoid arthritis, but by no means uncommon for the inflammatory process to involve the tendons and cause a tendinitis. And even more common than that is to cause an inflammatory process in the sheath that surrounds the tendon. That sheath is called the tenosynovium. So that process is called tenosynovitis. And it can cause pain, swelling, stiffness, tenderness on physical exam. of the tendons and the area surrounding the tendons. And that's in rheumatoid arthritis, very common in and around the wrists, though we can see it in other body areas. Gout is another very common condition in rheumatology. You may or may not be familiar with this one. It is caused by a buildup of uric acid crystals. And there's a picture on the bottom right here of those crystals. This is an image taken through a microscope. These are microscopic sized crystals that can lodge in and around joints. Generally speaking, they don't cause any acute problems, any acute symptoms, but they can cause discrete and very severe flare-ups of inflammation, pain, and swelling. On the top, on the right-hand side here, we have a specialized CT scan that's able to visualize these deposits of these gout crystals. And they're highlighted. They're the green areas are highlighted with the arrows. So we're looking at a knee joint here. On the left-hand side is the patella or the knee cap near the front of the knee. And more in the middle of the picture, towards the top is the femur or the thigh bone, and towards the bottom is the tibia, which is one of the main bones in the shin. And we can see these deposits are actually not in the joint space in between the bones, but rather they're right where the tendons attach to bones. So gout, it can cause inflammation in the joint, but these deposits can go into parts of the tendon. And when they cause flare-ups, it can cause very intense inflammation with redness and pain and swelling in the tendons themselves, because that's where some of these gout crystals lodge and deposit. Next is psoriatic arthritis. So psoriasis is a common inflammatory disease of the skin. We see a rather severe example of that on the right-hand side here. This is the back of someone's elbow and back of someone's forearm, and so they have psoriasis of the skin here. Psoriasis is associated with an inflammatory type of arthritis called psoriatic arthritis. Psoriatic arthritis, as the name suggests, causes inflammation of the joints, but it is also well known to cause inflammation of the tendons, a tendinitis, and similar to rheumatoid arthritis, it can cause a tenosynovitis, or an inflammation of that lining around the tendons. So one of the potential manifestations of psoriasis, or one of the ways that it can present itself in patients, is something called dactylitis, which is the swelling of an entire digit. So we can see in this foot, the fourth toe here is very swollen, very enlarged, all the way kind of from its base all the way out to the nail bed itself. And when we see this, oftentimes there is inflammation and swelling in the joint spaces themselves. But since this swelling is so diffuse, that often is a signal to us that the tendon, which runs its way all the way along the length of the toe, or in the case of the hand, along the finger, that tendon is swollen along its length, or the sheath or the lining of that tendon is swollen along its length. So that causes this condition called dactylitis, and that's fairly characteristic of psoriatic arthritis and related conditions. And last but not least is a condition called polymyalgiarheumatica, which is kind of a mouthful, so we call it PMR for short. This is a very inflammatory condition. It's seen mostly in older individuals above the age of 60 to 70 or so. Patients who develop this condition most often have very intense pain and stiffness that involves the shoulders, the neck, and the hips, buttocks, and thigh area. It's usually bilateral or present on both sides, and it's usually much worse for the patient in the morning time. So often patients who develop this condition will describe to their physician or their provider that when they wake up in the morning, they feel extremely stiff. They have a lot of difficulty moving their neck or moving their shoulders or getting up to move around because of the stiffness and the pain around their hips. And so what we're showing as an example here on the right-hand side is a PET scan. A PET scan lights up with areas of inflammation and metabolic activity in the body. This scan is sometimes used to detect cancers, which use a lot of, cause a lot of inflammation and use a lot of energy, so they light up or glow on the PET scan. But we can use it in rheumatology to find areas of inflammation. So the areas that are showing up the most are the brain up top, heart, and then the bladder. These are areas of a lot of metabolic activity and uptake in the brain and the heart. And then the dye that's used for the PET scan itself is excreted in the urine, so we see it in the bladder. So I want you to ignore those areas. What I want you to focus on here is around each shoulder. There's quite a bit of uptake, and also around each hip. And these areas are not directly located in the joints themselves. Instead, they're involving the soft tissues, including the linings of the tendons and the bursa that are around these joints. And so in polymyalgiarheumatica, it's largely a bursitis, tendinitis, and tenosynovitis. So an inflammation of the bursa, inflammation of the tendons, and the lining of the tendons that causes such stiffness and pain, particularly in the morning for these patients, and causes high levels of inflammation in the blood, which are detectable when we do laboratory work for these patients. The last inflammatory process I'd like to touch on is an infection. So I highlighted early on in the talk the distinction between non-inflammatory causes of tendon or bursa disease. Within the world of inflammatory diseases, it's important to sort out the infectious from the non-infectious. So all the conditions I just touched on, rheumatoid arthritis, gout, psoriatic arthritis, and polymyalgia rheumatica, or PMR, are non-infectious processes. And by and large, they're treated by using medicines that calm down the immune system. Now, that's important to distinguish from an infectious cause of inflammation, where we would not want to calm down the immune system, which is doing its job appropriately to combat an infection. And instead, we'd want to identify the infection, the type of infection, and use antibiotics or other appropriate treatment strategies for the infectious process. So we see here on the right a rather extreme example of an infectious bursitis. This is overlying the elbow. So again, this is the Olecranon bursa. So this is an infectious Olecranon bursitis. You can see that it is quite swollen, quite red. You can imagine that this would be very, very tender to the touch. This bursa, the Olecranon bursa, like the Prepatellar bursa in the knee, I've mentioned a couple of times now, is very superficial. It is near the surface of the skin. So these two bursa in particular are susceptible to trauma and some form of penetrating trauma. So something that makes its way through the skin, doesn't have very far to go before it enters the bursa itself. And you know, a cut, a laceration, a foreign object, anything of that sort could deposit a small amount of bacteria that could then set up an infection in the area. So these sorts of infections are treated with antibiotics, often with antibiotics and monitoring and supportive measures. That's enough to resolve the infection itself. But in these instances, we a little bit more frequently will go ahead and sample the fluid, so draw some fluid out of the bursa with a needle in order to figure out what exactly is causing the infection. And if need be, if the patient isn't getting better with antibiotics, sometimes surgery is needed to clear out the full extent of the infection. All right, so just a few take-home messages before we get to questions, and a little bit of a recap. So bursitis and tendinitis, these are very common causes of musculoskeletal pain, as well as debility and lost time at work. There are many different underlying causes. We've covered a few of them here today. Bursitis and tendinitis are, however, often misnomers. Many patients experience tendinopathy or bursopathy, which is not inflammatory in nature. Though we did review a number of the inflammatory conditions that we treat as rheumatologists that can cause bursitis or tendinitis as a part of their disease processes. And the treatment options are very broad. They vary to some degree based on the nature of the tendinopathy or the nature of the bursopathy, as well as the location of the tendon or the location of the bursa that's affected. But there are common themes here. Oftentimes we'll start with kind of the safest and the least invasive options and work our way up to using cortisone injections or as a means of last resort, a surgical procedure if a patient has ongoing symptoms or ongoing problems with the bursa or the tendon. So I'd like to say a couple of quick acknowledgements. First, I'd like to acknowledge our patients who teach us so much about tendons and bursa and everything else about the human body, and whom we strive to help with these sorts of conditions. I'd like to thank Dr. Keller for being here for today, but also teaching me so much about tendinitis and bursitis and ultrasound, which she and I use to evaluate and treat these conditions. And Dr. Bolster, who I'm not sure was able to make it today, she's the program director, and she's also taught me so much about these topics. And likewise for my co-fellows here at MGH in rheumatology. And lastly, I'd like to thank everyone who's come to the talk today for your attention and look forward to any questions.
Thank you, Dr. Cooley, for an engaging talk. We learned a lot about the differences between bursitis and tendinitis versus bursopathy and tendinopathy. We have a couple of questions in the chat, so I'll go through them. How long after trying home treatment methods should I seek medical evaluation for a bursopathy?
Yeah, that's I think, good and common question. You know, I think there are a couple of reasons to seek medical attention if you think you may have a bursopathy. The first reason would be to try to confirm the diagnosis. We've spent quite a bit of time talking today about bursopathy and tendinopathy. And I highlighted some of the differences. I didn't so much highlight the overlap between those two in terms of the symptoms that patients can experience. And sometimes it can be challenging to understand what is the cause of the symptoms. So I think if you're having ongoing symptoms, you know, seeing your primary care provider, seeing a rheumatologist or another specialist who deals with musculoskeletal symptoms and musculoskeletal disease is very reasonable to confirm the diagnosis. And certainly if you're having ongoing symptoms that can, you know, help alleviate those symptoms, help to kind of work through the other options for treatment.
And I think, as Dr. Cooley highlighted in his talk, if you have ongoing symptoms of what you think is bursopathy that's not, you know, responding to conservative measures, it may be that there's actually another process going on, such as infection, inflammatory etiology, or even mechanical tears of the tendon or, you know, cartilage breakdown. Next question. Dr. Cooley, can you talk about the relationship between Achilles tendinitis and plantar fasciitis? If there's pain in the area below the ankle, is it considered tendinitis, tendinopathy? Can you clarify these conditions?
Yeah, so the Achilles tendon we looked at in a couple of the images in the talk. That's the one that comes down from the large calf muscles and it attaches on the calcaneus, which is that bone on the backside of the foot and the backside of the ankle. One can certainly have a tendinopathy or, you know, including a tendinitis in that area. Plantar fasciitis it involves the connective tissue on the bottom aspect of the foot. It attaches, the plantar fascia attaches also to the calcaneus, but on the undersurface of it, on the bottom aspect of the foot. So someone could have an Achilles tendinopathy or a plantar fasciitis, or they could have a combination of both. It's not uncommon for us to see both kind of coexisting with each other either because they have an inflammatory disease that's affecting both of those structures, or they have a non-inflammatory disease, but they compensate in terms of how they walk or how they move or how they do their activities because of one condition, and then that can predispose them to the other condition. So it is quite possible to have both, and they can be inflammatory, non-inflammatory, or a combination of the two.
So to dovetail off that explanation, if a patient has seen orthopedics for supposed plantar fasciitis or tendinitis pain, and is told that from a mechanical standpoint that it's actually healed, but they're still continuing to have pain, would the next step be to see a rheumatologist?
I think in some instances that would be appropriate. You know, the non-inflammatory causes of these symptoms and of these disorders are more common than the inflammatory causes of these disorders. But it's not infrequent for patients to see orthopedics first, and if there are recurrent symptoms or refractory symptoms after addressing the mechanical factors, it may be that the true problem is an inflammatory one. And the rheumatologist is better positioned to kind of assess and be able to tease that out if it's a more subtle presentation.
Thank you. So you talked a lot about treatment options being similar between bursopathy and bursitis, tendinopathy, tendinitis. If a patient has rheumatoid arthritis, how does treatment options differ?
That's a great question. That highlights something that I'm not sure I highlighted in the talk itself, and that is that the treatment of the inflammatory conditions that I mentioned are really systemic treatments or body-wide treatments. Because the nature of the disorders is inflammatory, you know, in rheumatoid arthritis, for instance, we may be a little bit more prone to give corticosteroid injections or cortisone injections, which can locally reduce inflammation. But if someone has a lot of inflammatory disease or persistent inflammatory disease from rheumatoid arthritis, the real kind of more definitive and long-lasting treatment is a systemic treatment. So that's going to be an oral treatment or perhaps an infusion that addresses more body-wide inflammation that is just manifesting or showing itself in a tendinitis or a bursitis.
So if you're on systemic treatment for rheumatoid arthritis with oral medicines or injectables, is there still a role for steroid injections to specific joints or bursa or tendons?
Absolutely. You know, in some instances, if a patient is on one of these systemic treatments, for instance, for rheumatoid arthritis, and they have active inflammation in bursa or around tendons, you know, that may prompt the rheumatologist to make a change in their systemic treatment. But if they're otherwise doing well with that treatment and it's just one spot here or there, then certainly the rheumatologist could use a local therapy like an injection to help kind of get that one more stubborn area over the hump and then keep them on their current treatment regimen.
Another question here on different disease process. Can you talk about the treatment for gout, and is this a lifelong condition if under control?
Yes, so gout from the big picture standpoint has kind of two treatment goals. One treatment goal is when there's a flare-up is to control the inflammation. Controlling the inflammation will help to control the symptoms and the swelling associated with that flare-up. But the second goal, which is kind of in parallel, is a long-term goal. And it relates to the question about whether or not this is a lifelong condition. This is a lifelong condition. And the long-term goal is to decrease the uric acid in the blood, because it's high levels of uric acid in the blood that predispose someone to develop uric acid crystals. And it's the uric acid crystals that lead to gout. Those kind of little clumps of green that I showed on the CT scan are the uric acid or gout crystals. So on the one hand, we want to treat to make those crystals go away and stay away lifelong. And on the other hand, we want to treat in the short term for the inflammation associated with the flare-ups.
Another question about gout, is it hereditary?
So there certainly are hereditary elements to gout and to essentially how much the body holds on to uric acid. This is mostly handled by the kidneys. Our kidneys make urine and they help to excrete products in the urine and kind of balance levels of uric acid in the blood. And so based on some genetic factors, some people's kidneys hold on to more or less uric acid than others, and that can predispose them to gout. So it's generally not strictly genetically driven, but genetics certainly can predispose to gout.
Sometimes people present with ankle tendinitis or plantar fasciitis. Could this also be related to gout?
That could be. I showed an example of a CT scan of the knee and showed some of those green deposits in the tendons around the knee. Gout often involves the foot and the ankle area, and in an analogous way, it can deposit in the tendons and the soft tissues around the foot and the ankle. So if someone develops tendinitis or plantar fasciitis around the ankle and the foot, that could be from gout deposits and inflammation from gout. I think probably the thing that helps us the most to sort out whether that could be gout or not is if that person develops distinct flare-ups. That's very, very characteristic of gout, most often in the joints, but it can involve areas outside of the joints, but it tends to behave the same way where it causes no problems for a period of time, and then all of a sudden it flares up very acutely and severely. So that would be a strong clue that maybe gout was the cause.
And one last question to end the hour. How are pediatric shin splints from sports different than tendinitis, or are they similar?
So shin splints, be they pediatric or adult, involved different structures. So the tendons we mentioned attach between muscles and bones, and the bursa were those closed sacs that we reviewed. The primary area of involvement in shin splints is around the bone, involving the periosteum, which is kind of the lining connective tissue around the bone itself. Sometimes the tissue of the bone can be impacted, when things progress to the point of stress fracture. But it's involving separate tissues, similar kind of underlying risk factors and repetitive use, repetitive trauma, micro traumas, and eventual progression to symptoms. So similar underlying process, but slightly different in terms of the tissues that themselves are being affected.
Thank you to all our attendees for the wonderful questions, and thank you to Dr. Cooley for an informative talk and answers to these questions. And we thank Amy at the Blum Center for the opportunity to share this information with you.
Thank you so much. And as I had mentioned, today's session is being recorded. So if you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone, for joining us. Have a lovely rest of the day.
Bye. Thank you.